Hello everyone. I hope that you all are doing fine. And so we will start with today's pages that we need to do. So this is nitroimidazole used in dentistry. The nitroimidazole that we commonly prescribe to our patient is mainly the metronidazole. It has mostly anaerobic it acts against mostly the anaerobic bacteria. So that's the reason we usually combine the metronidazole with amoxicillin, because amoxicillin is mainly for the aerobic bacteria and metronidazole is for anaerobic bacteria, which are mainly Peptoniphilus species, P. gingivalis, P. oralis, B. fragilis. Metronidazole can cause nausea, vomiting, flushing, headache, and palpitations if taken concomitantly with the alcohol. So it is very important that you make sure that you told your patient that do not take alcohol with the metronidazole because it can cause these reactions. Advise patient to avoid alcohol during treatment. Like if you are prescribing the metronidazole, for example, 3 days or 5 days, so advise your patient do not take alcohol in that period and for at least 24 hours after completing the course of metronidazole. So you need to give this full description. So whenever you will be prescribing metronidazole, just keep in mind this box that you need to advise these two things, that avoid alcohol during the treatment and at least 24 hours after completing the course. In these guidelines, the recommended dose of metronidazole in the therapeutic guideline, it is mainly recommended if you are prescribing metronidazole orally, which you would be prescribing because we can only prescribe the oral dose and IV dose is given mainly in the hospitals. So oral dose is mainly only 400 milligram. And if you need to prescribe IV, it would be 500 milligram, and its dose is always 12 hourly, so only 2 tablets in a day. The metronidazole dosing regime is based on pharmacokinetic data and minimum inhibitory concentration of the pathogens involved, in addition to limited clinical studies and extensive clinical experience with its use. Then tetracycline used in dentistry. So tetracycline is very, controversial topic. We do not really prescribe tetracycline easily to the patient because it does have many side effects. So there is the reason is because it is a broad spectrum antibiotic, and we already studied that the best ones are the narrow, then the second one are the moderate, and the broad one we try to avoid using them, right? So the doxycycline is only the preferred dental indication that we use, and I think it's only used in case of trauma if there is any avulsion of the tooth. In those cases we do prescribe, otherwise we do not really prescribe doxycycline anywhere. Doxycycline has not been associated with because with the tetracycline in the past, if the kid has taken tetracycline during the growing stage of his teeth, so then these antibiotics can interfere with the tooth formation and maturation, and they can cause discoloration of the teeth. That's the reason we were not very keen on prescribing these antibiotics. But later on, this doxycycline, which has discovered, and they state that this doxycycline is not associated with the tooth discoloration, enamel hypoplasia, or bone deposition, even in children younger than 8 years. It means that whenever their teeth would be forming, so is increasingly used in this age group. So you can even prescribe the doxycycline in the kids who are younger than 8 years, for in which the teeth are forming. However, use is limited by the lack of suitable commercial available formulation, because in kids, in Australia they do not prescribe tablets to the kids generally. There is only liquid formulation available. So its use is not that much because its liquid formulation is not available. So the side effects of doxycycline is esophagitis, and oral doxycycline should be taken with food and a large glass of water. Previously, we studied that the other like ferroxymethyl penicillin and the penicillin, we should not be taking it with with the food because that can impair its absorption. But with the doxycycline, it is like you take it with the food and a large glass of water, and the patient should remain upright after administration. Photosensitivity reactions can occur with tetracycline. Warn patient to avoid sun exposure. So these are some of the precautions and some of the advices that you need to mention to your patient, which is take it with the food and a large glass of water, stay upright after administration, and a photosensitivity, like try to avoid sun exposure. All right. Then the antifungal drugs used in dentistry, those are the azole antifungals used in dentistry, which are mainly miconazole and cotrimazole. They are both broad spectrum antifungals available in topical forms, either alone or in combination with hydrocortisons. Use of topical azoles on the skin is generally well tolerated. Oral miconazole gel can cause mild GIT adverse effects. A systemic absorption of miconazole can occur when applied topically to the oral mucosa. So they are generally applied topically, but if the patient takes oral miconazole, they can cause GIT adverse effects. Azole have many clinically significant drug interactions. So consult an appropriate resource on drug interaction if starting or stopping azole in patient taking other. So it is very important for you to understand if the patient is taking any other drug, because these azole derivatives, they have so many interactions with other drugs. Then the polyene antifungals. So antifungals are of two types, azole and polyene. Azole are miconazole and the cotrimazole, and the polyene are nystatin and amphotericin B. They are active against Candida species. They are poorly absorbed orally and not absorbed through the mucosa when applied topically. So do not cause any systemic effect or drug interaction. So it's their benefit. Okay, so their benefit is like their disadvantage was they can be absorbed systemically and they can cause so many drug interaction, but their benefit is that they do not do any systemic effect. They are not absorbed. They are not absorbed orally, and they do not do any drug interactions. Nystatin suspension has a high sucrose content, but their disadvantage is nystatin has a very high sucrose content. Like and nystatin suspension is very sugary in nature, so it is very important that we make sure that because that can accumulate more plaque and can lead to decay. Otherwise, topical intraoral polyenes have few adverse effects. Taking amphotericin lozenges after food reduces the risk of nausea. So take the amphotericin lozenges is just like the sucking tablet that you need to you all know. So take it after the food, so there would be less chances of nausea. All right, then antiviral drugs used in dentistry, those are mainly acyclovir and famciclovir, and are guanine analogs, antivirals with activity against herpes simplex virus. So if the patient has herpes simplex virus, okay, so in that stage you can either prescribe him oral famciclovir or topical acyclovir is available. The oral famciclovir, you just only need to prescribe in a single dose without a prescription as a pharmacist only. It is Schedule 3 medicine, so you should you should prescribe one dose. medicine for the treatment of recurrent herpes simplex virus infection of the lips, which is herpes simplex labialis or cold sore. So if the patient has primary herpes simplex viral infection, which is the first time he's having, and it generally have the so many systemic features, and so in that case these antiviral drugs are not very helpful. These antiviral drugs are helpful in cases of recurrent infection of herpes simplex virus, which mainly occur on the lip and which is also mainly known as cold sore. So in that prodromal stage, if you would apply, if you would prescribe your patient to apply oral famciclovir, then it would be helpful. And the other drug that you can mention is the topical acyclovir. It is the preferred topical antiviral for recurrent herpes simplex viral infection of the lip, because it is preferable because it only requires 5 applications per day, whereas the other topical antiviral, which is the pancyclovir, it requires 6 applications. So that's the reason it is you know acyclovir is better than pancyclovir because it requires less number of application per day. Adherence can be challenging because of the frequency of application required, because it is very hard for even a patient to just 5 6 time applying a drug. It's difficult, right? So topical acyclovir should not be applied to mucous membrane, example in the mouth, eyes, or vagina, because it may be irritant. So this cream, the topical acyclovir drug, you should not be asking the patient to apply on the mucous membrane. It should only be on the skin because it can cause the irritation. Okay, then drugs used to treat acute pain. So the antibiotic topic is over here. Antibiotic, antiviral, antifungal topic is completed. So now we will start with the painkillers. So this is just the normal introduction um, paragraph in which they say that this topic covers practical information on drugs used to treat acute pain in dentistry. For comprehensive drug information, including precautions, contraindications, adverse effects, and drug interactions, consult an appropriate drug information resource. If prescribing an analgesic drugs or local anesthetic, consider the benefit harm profile of the drug in the individual patient. This requires knowledge of the patient's medical history before prescribing any medicine. Make sure that you have weighed the benefit harm profile. Then you should have the knowledge of patient's medical history, any additional medication he might be taking, including prescription, over the counter, or any complementary medicines. Okay, so all after knowing all these things only, you should prescribe the patient the medicine, even be it antibiotic or be it painkillers. So NSAIDs, which are the non-steroid anti-inflammatory drugs used in dentistry, include non-select. So there are two types. First one is the non-selective cyclooxygenase inhibitors, and the second one is COX-2 selective inhibitors. Okay, so the non-selective ones are ibuprofen, and COX-2 selective are the celecoxib. So for the ibuprofen, you should advise the patient to take the dose 3 or 4 times daily. For the celecoxib and for the naproxen, it is 1 or 2 times daily. Okay, so naproxen we do not really prescribe anywhere according to this book, but you should remember the dose of ibuprofen and celecoxib, because in certain cases we cannot prescribe ibuprofen. In those cases we can prescribe the celecoxib. Okay, so the frequency of administration gives an indication of the drug's half-life. We all know that this like the if you need to ask the patient to take the drug 3 times, 4 times, or 1 time or 2 times, it all depends on the pharmacokinetics, right, and the half-life. So that's the reason. Immediate release naproxen is dosed twice daily, and modified release naproxen is dosed once daily. Then, what are the major adverse effects of the NSAIDs? You should know. Just try to remember that NSAIDs work on every organ of the body, like be it kidney, heart, stomach, lungs, and blood. Okay, so they would act on every, and what they would do if they would act on kidney, they would impair the kidney and can increase the risk of acute kidney failure. If they are acting on heart, they would increase blood pressure, fluid retention, worsen the heart failure, thrombosis, myocardial infarction, stroke, cardiovascular death. If they are acting on the stomach, they would cause the esophageal, gastric, duodenal, and small bowel ulceration, upper abdominal pain, gastric erosions, gastrointestinal bleedings. And on the lungs, they would cause bronchospasm in patient with NSAID exacerbated respiratory disease. Okay, so and in the hematological, they can impair the platelet function. So you should be very careful while prescribing the NSAIDs to the patient. Like for example, if the patient has any kidney problem, you should not be prescribing him NSAID. If the patient has any heart related problem, we will study in the later pages, like in which cases we should avoid totally and in which case we may consider some type of NSAID. But you should know that be more cautious in these patients. If the patient has any cardiovascular problem or any GIT associated, like any bleeding or any other problem, or he has asthma or any other respiratory problem, or he might be taking any other concomitant drug like warfarin, and so in that cases you should be very careful. The adverse effects occurs with non-selective NSAIDs but not COX-2 selective NSAIDs. Okay, so these adverse effects are with ibuprofen and naproxen, not with the celecoxib. NSAIDs are the um, um, preferred drug class for acute dental pain. We all know that the best drugs for the acute dental pain is the NSAIDs. The reason is because the dental pain is inflammatory in the nature, and these drugs are anti-inflammatory. So that's the reason they are the best one. However, they can cause significant renal, cardiovascular, GIT, respiratory, and hematological adverse effects. The risk of harms from NSAIDs increases with, so the risk would increase with the increasing age of the patient if he is taking higher dose, if he is taking the NSAIDs for longer duration, and if there is any concomitant use, like for example, he is taking any other drug as well. Okay, so the adverse effect would increase. So now you need to assess whether NSAID is appropriate in your patient or not. So they are preferred analgesics for acute dental pain because of their anti-inflammatory action and efficacy for bone pain and ability to reduce opioid requirement, nausea and vomiting, and improve pain relief when used as a component of multimodal analgesia. Multimodal analgesia means if the patient has more severe pain, you can either add NSAIDs plus paracetamol. So that can, reduce the chances of you to prescribe any opiate to the patient, because, opiate has major disadvantages and it has major adverse effects. So we try avoiding prescribing um, opiates. Before prescribing an NSAID, weigh these potential benefits against the potential harms. In the individual, the risk of harm depends on patient's factor and the NSAIDs used. So we will discuss the patient factors and the NSAID, like which type of drug we are using. Consider assessing the patient's electronic health record to obtain more information on their health status. If unsure of the safety of short term use of a patient, consult a medical practitioner. If anytime you are not 100% sure, like can you prescribe this drug to the patient, can you do this treatment to the patient or not, always consult, always consult. There is no harm in asking for help. That's what they want you to learn. Do not be, overconfident. Do not be like they would think, like as a dentist you do not know anything. Just be more clear, because your confidence is one thing but patient's life is other thing, right? So if you are not sure, it can um, damage patient in some way. It can be harmful, so always make sure. For information on choosing an analgesic regime for patients at risk of NSAID related toxicity, we will read in following pages. There is a low risk of harm when NSAIDs are used for short term by healthy people who are not taking any other medicine. So it is definitely opposite from this line. Like if we are taking if one patient which is healthy and he's younger age and he's taking this medication for the shorter duration of time and he's not taking any other medication, then the risk of the harm would be less as compared to the other. However, even in these patients, steps should be taken to minimize harm. For practical advice to minimize harm, I'm prescribing. Okay. So conversely, NSAID use is contraindicated in some patient. In some patient, you should not be prescribing the NSAID, no matter what it is. Okay, and should be avoided in other because of significant risk of harm. So we will read this box in which they have mentioned. For patient who should not be prescribed an NSAID by a dentist, if paracetamol is not expected to provide significant analgesia in this patient, consider alternative pain management strategies or refer the patient to a medical practitioner. Okay, so if you got a patient, like for example, he has asthma and you cannot really prescribe him ibuprofen, right? So in those cases, you can prescribe him the paracetamol, and you know that the paracetamol does not have anti-inflammatory properties, so it won't be very helpful if the patient has too much pain. So what you can do is you can either refer him to the his GP, or you can talk to his GP for the pain management strategy, like what else you can do for him. Deciding whether it is safe to prescribe NSAID in patients with risk factors for NSAID induced renal, cardiovascular, or GIT toxicity is more complex. Consider the cumulative risk of NSAID toxicity if more than one risk factor is present. The use of these drugs in elderly patients and pregnant or breastfeeding women requires extra considerations. Although most of the evidence for NSAIDs are as part of multimodal analgesia comes from post-operative pain, the findings are considered irrelevant for most acute and organ. So these are the patients where you should not be prescribing this drug. Which are these patients? If the patient has severe kidney impairment, because you know the NSAID acts on kidney. Okay, and if the patient has severe heart failure, because you know that these drugs act on heart. If the patient has active GIT ulcer or active bleeding, then you should not be prescribing, because it would only increases the chance of these things to happen. Then, if the patient has any bleeding disorder, because NSAID impair the platelet function. If the patient is taking corticosteroids or anticoagulant, because anticoagulant would also impair the blood coagulation. So if you would prescribe them the NSAID, then the risk of bleeding would be more. And if the patient has multiple risk factors, for example, they are elder and they had a history of gastrointestinal bleeding. Okay, so renal toxicity. If the patient has acute kidney injury, is a serious adverse effects associated with all NSAIDs. Risk factor are this can occur, like the acute injury can occur in patient who are older in age, who had pre-existing kidney impairment, who had volume depletion, like for example dehydration, sepsis, or they are arterial volume depletion, for example heart failure, cirrhosis, nephrotic syndrome, or they are using the diuretics or any other ACE inhibitors or angiotensin 2 receptor blockers. The risk of acute kidney injury is cumulative. For example, the risk is significantly increased if an NSAID is co-administered with an ACE inhibitor plus a diuretic. Okay, so if the patient has already, his first risk factor is he is old. Okay, so this is the main risk factor. The other risk factor is he already has some kidney problem and for which he is taking these drugs. Okay, so there are three risk factor in this case: his age, his pre-existing kidney impairment, and the other concomitant drug. So in these patients, the risk of acute kidney injury is more. Okay, and try to avoid prescribing NSAID in patients who are already taking ACE inhibitor plus an diuretic, or if an older patient taking an NSAID develops an acute illness associated with dehydration. To choose an appropriate analgesic regime for patient at increased risk of renal toxicity. So what to give? Like if the patient has patient is taking, patient has all these four factors, what painkiller we can prescribe him? So we will read in this page 48. Okay, so here they have written the choosing an analgesic regime for patient at increased risk of NSAID related toxicity. So first of all, for kidney problem, consult with the medical practitioner if unsure. Okay, recognize patients that should not be prescribed NSAID by a dentist. If a paracetamol is not expected to provide significant analgesia in this patient, then consider alternative pain management strategy or refer the patient to the GP. And if the patient has a risk of renal toxicity, which are these patient which has these four factors, in those patient what you need to do is only to consult a medical practitioner and should always prescribe only paracetamol, or just talk to their GP. Do not prescribe them NSAID at all. Okay. Then the second types are the cardiovascular toxicity. Although all NSAIDs can cause cardiovascular toxicity, not all are equally likely to do so. Evidence is evolving. Furthermore, the relationship between the duration of NSAID use and the onset of toxicity is not fully understood. It is clear that the risk of cardiovascular toxicity increases with longer duration of therapy and higher dose. Like the short term use, for example, less than 5 days of NSAID does not significantly increase the cardiovascular event and can reduce the risk of opiates. So here they have written, if you are prescribing the NSAID, some type of NSAID to the patient for the shorter duration, that is less than 5 days, it won't significantly harm the cardiovascular event. But from this statement, I don't think they have given us the clear cut answer. So I would say, like, check with their GP would be the most suitable answer for this. The risk factor in which these toxicity can increase is if the patient already has MI or stroke history, or the other risk factor are like the patient is smoking, he is older age, or he has BP issues, dyslipidemias, and diabetes. In those cases, it is very important that you would consider. So what they have written here is, recognize patient at increased risk of cardiovascular toxicity, then consider that ineffective pain relief can cause. Okay, so if the patient has any cardiovascular toxicity risk, we also need to weigh the benefits and harm, in which if we do not provide accurate pain relief to the patient, then due to that pain they would have the tachycardia, and that could also be very dangerous condition, right? So we need to be more cautious with them. Avoid diclofenac and COX-2 selective NSAIDs other than celecoxib. Use celecoxib or ibuprofen, and but limit treatment to 5 days. Naproxen can also be used but has a higher GIT adverse effect. So for the kidney patient, do not use any other NSAID. Only prescribe the paracetamol. For cardiovascular, you can prescribe them celecoxib or ibuprofen, but should not be more than 5 days. If celecoxib, ibuprofen, and naproxen cannot be used, if they cannot be used, then use only paracetamol for mild to moderate pain. In adults, paracetamol with oxycodone. For if they have mild to moderate pain, then only use paracetamol. If they have severe pain, then use paracetamol with oxycodone, but always talk to their GP. That would be the best answer. All right, so we will continue from this topic in the next class. All right, thank you so much, guys, for watching my videos. And always like, share, and subscribe if you can. And if these videos are really helpful for you. All right, see ya. Have a good day.